You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for September 12th, 2025. This week, a correction, some more ESC studies, including valvular heart disease guidelines, a new drug class for hypertension, myosin inhibition in hypertrophic cardiomyopathy, Vericiguat, and more Digoxin news. First up is a correction. The PI of the Dan Block trial, Professor Eva Prescott from the University of Copenhagen, emailed me some comments. First of all, that's a nice thing to get an email from Copenhagen and from a PI. Less nice is that I made an error both in my column on Medscape and on my podcast last week about the reboot trial, the Spanish RCT of post-MI beta blockers. I said and wrote 4,000 patients were randomized. That is wrong. It was actually 4,000 per arm for a total of 8,000, so sorry for the mistake. Professor Prescott also disagreed with my less than enthusiastic embrace of the subgroup finding in patients with mild LV dysfunction, EF 40 to 49%. She felt that while the absolute risk reduction of one event per 100 patient years is not dramatic, the relative risk reduction of 25% is on par with statins and aspirin. Quote, in that context, beta blockers may still have a role. They are inexpensive, safe, and have been part of cardiovascular care for decades. Moreover, studies in heart failure with LVEF 40 to 55%, including a meta-analysis by Cleveland et al., suggest benefit in these patient groups overlap considerably. Thank you, Professor Prescott. All right, first topic is new valve guidelines released at ESC. While in Madrid, a number of people asked me to review the new ESC valvular heart disease guidelines, and there was no way to do it while there because the document is massive. And there were tons of trials to discuss at ESC. Now, there are still trials, but let me hit some of the highlights of this valvular heart disease document. Note here that I'm an EP doctor. I approach the problem as a neutral Martian, and I look mostly at evidence because I don't do a lot of valvular heart disease management. I have partners who help me. The first issue with the guidelines is that CTA before valvular heart disease surgery is now favored over doing coronary angiography. Gets a class 1B recommendation. And understand this, it makes sense, right? You want to identify left main or other severe disease because the evidence for revascularization is really quite minimal. But the two of the three studies cited in the guideline documents to upgrade to a class 1 recommendation are small observational studies, and one is a meta-analysis of sensitivity and specificity studies. Now, I mention this because this hardly seems like class 1 guidance, but this is the problem with guidelines. Here's a recommendation that just could be a suggestion. They could say, just consider CTA. It's probably just as good, but giving it a class 1 clouds the level of class 1 recommendations. Okay, second issue is intervention in asymptomatic patients with severe AS, and this gets a 2A. But I've already written multiple times about the problems with the studies. There were two very small surgical trials with few numbers of events. The big trial, called the early TAVR trial, was completely biased because planners chose an endpoint of death, stroke, and rehospitalizations for cardiac causes. And the latter component drove the endpoint, and most were due to conversion to TAVR very early. So early TAVR is an important trial because few better examples of subtraction anxiety exist. You have patients with severe AS. They know they have severe AS. They get a complete pre-TAVI workup, including the CT scan. Then they get randomized to nothing. Now, of course, immediately they turn short of air and quickly. Again, I have no doubt that there are some patients with asymptomatic severe aortic stenosis you might want to intervene on. But when there is a 2A recommendation, this will increase the amount of TAVIs done, and early TAVR was sponsored by a TAVI valve company. So, third issue. The age cutoff for TAVI versus SAVR was decreased. This was based on the NOTION trial. The mean age of patients in NOTION was 74 years. The cutoff was gone from 75 to 70 years. Again, I think there are some younger patients who are probably best served by TAVI. But by doing this, you increase the number of young people who will get TAVI over surgery. And, of course, if you're operating on younger people, we don't have 10 to 20-year data, and that could be important for a 70-year-old. Now, in all likelihood, the TAVI-SAVR results are going to be close, but we don't know yet. And I get it. TAVI is clearly an easier short-term choice, but young people ought to have frank discussions about uncertainty regarding the long-term outcomes and reoperative rates. The fourth issue is transcatheter edge-to-edge repair for severe tricuspid regurgitation. It gets a 2A recommendation based on Triluminate trial, which is also another cynicism-inducing trial where transcatheter edge-to-edge repair was compared open label to medicines in patients with severe TR. The trial had a primary endpoint of clinical endpoints and quality of life questionnaire. The quality of life is what drove the endpoint. The clinical endpoints were unchanged. And as I've said many times, the transcatheter edge-to-edge repair trial, Triluminate, could have easily had a sham control arm. And without that, we just don't know. And again, the same story. There are probably patients who may benefit from this procedure, and I've even referred patients to our structural team for consideration. But with a 2A recommendation there, it is ripe for overuse. A fifth issue is surgical ablation of AFib in patients suitable for rhythm control during any valvular surgery gets a 2A, and during mitral valve surgery gets a 1A recommendation. And the authors list 7 references, and only one is a proper RCT, and that's the Gillenov New England Journal of Medicine trial. The other ones are observational studies and meta-analysis. The best meta-analysis out of the McMaster University, first author McClure, finds moderate level evidence suggesting a reduction in AFib with surgical AF ablation, no difference in stroke and mortality, and a higher rate of pacemakers. There is no way, in my mind, this level of evidence can guide any recommendation. Plus, there are multiple versions of surgical ablation. I find the lack of study in this area, the surgical ablation, surgical patients, to be woefully bad. It's kind of an embarrassment, really, that we don't have evidence. It's crazy because it would be so easy to study. You just randomize patients to surgical AF ablation versus not. And if I were evidence czar, I would immediately stop the add-on code for surgical ablation unless a patient was in an RCT. The problem is that if a surgeon can clip the PVs and do something really quick and get extra dollars from the case, there's no incentive to get proper data. We need data on surgical AF ablation. And finally, a couple more comments. I just don't like these colored boxes where complex decisions are made far too simple. It totally belies the complexity of decision making. I know many of you disagree with that. You say we need guidelines, we need these little boxes to tell us what to do. But if I were writing guidelines, I would just do the narrative reviews, give the references, and leave out the simple boxes. I believe that doctors should be able to read studies, especially those making complex decisions on patients. And if you disagree with this, and you say, Mandrola, you can't expect doctors to understand studies, then I ask you this: in the era of AI and LLMs, what will doctors be for, if not to meld evidence with experience? The doctor of the future will have to prove their worth beyond Claude or ChatGPT. Now, the writers emphasized a multidisciplinary heart team, and this is hard to argue with. It's a good thing. My only addition would be that patients get the minutes or the video of their case. If I faced valvular heart disease intervention, I'd love to hear the candid comments of all the clinicians in the MDT. All right, next topic: is there a new drug for resistant hypertension? The headline of the news article covering the BAX hypertension RCT of the aldosterone synthase inhibitor baxdrostat includes the 2 words game changer. When presented in the big hall in Madrid, the results earned a round of applause. And gosh, I do not like that when doctors applaud scientific results. Now, game-changing, these are big words. When you see these words, you should fire up your critical appraisal skills. Antibiotics were game changers. Insulin was a game changer. Maybe PCI for STEMI was a game changer. But a new blood pressure drug? Maybe. Let's get into this phase 3 placebo-controlled trial that was sponsored by and partially written by the makers of this drug. But first, a couple background points. The trial studied patients with resistant hypertension who are on multiple drugs. Now, resistant hypertension is known to be associated with high aldosterone production, which causes sodium and fluid retention as well as potassium loss. Now, one way to approach resistant hypertension is to block the effects of aldosterone with mineralocorticoid receptor antagonists like the $4 per month spironolactone. The problem here, as everybody knows, are side effects. So the potentially game-changing new way is to block the production of aldosterone by blocking a key enzyme in the pathway, aldosterone synthase. In the spring, New England Journal of Medicine published an RCT called the Advanced Hypertension Trial, showing that an oral aldosterone synthase inhibitor called lorindrostat reduced blood pressure over placebo in patients with resistant hypertension. At ESC, the BAX Hypertension Trial studied a different aldosterone synthase inhibitor called baxdrostat. There were 3 arms, 1 milligram, 2 milligram, and placebo. The primary endpoint was a change in seated systolic blood pressure from baseline to week 12. First interesting finding was that the placebo arm reduced blood pressure 6 millimeters of mercury. That's a lot. It was 14.5 millimeters for 1 milligram and 15.7 millimeters for the 2 milligrams of the drug. So the delta was 8.7 millimeters for 1 milligram and 9.8 for the 2 milligrams, and both were statistically significant. Comparisons, hyperkalemia was more common in the baxdrostat arm. Much was made at ESC that the blood pressure effect seemed to continue after stopping the drug. An expert commented on our news story that the most interesting effect was related to durability, with only a minimal rise in blood pressure when the drug was stopped. And this expert felt like this might indicate that there is a minimal rebound despite drug clearance, and commented that, quote, "We are not dealing with a drug-on, drug-off effect, but with resetting of some physiologic or pathophysiologic mechanism involving sodium handling, and it shows that we have a medication that not only efficiently lowers blood pressure, but actually changes underlying disease trajectory." Well, my comments, I'm not so sure about the game-changing part of this. It's an interesting drug discovery story. Maybe it's going to pan out, but the supplement yields the important data point, I think. Nearly 0 of these resistant hypertension patients were on spironolactone or any other MRA. So the effect size was about 10 millimeters of mercury, which is pretty good. Not amazing, but surely better than the almost nothing you get with renal denervation over 6 months. My question would be, what would the effect of this drug be if patients were on an MRA? I think it would be much, much less. Then you have to consider there's going to be huge cost and the problems with hyperkalemia. I am not sure that this drug class is going to be a game changer. Maybe it will prove an important drug class in patients with hypertension or maybe even heart failure, but I'm not sure. Also, as everybody knows, most resistant hypertension is simply because patients do not take their pills, which is not a criticism of the trial, but a fact of human nature. Because I cannot remember to take my asthma puffer, and that is related to symptoms, and hypertension causes no symptoms. And finally, it really bugs me to no end that researchers let medical writers that are employed by the company write scientific papers in the New England Journal of Medicine. I'm not saying there's any malfeasance or bad things going on. It just doesn't look good that a medical researcher is not writing the paper themselves. Okay, next topic is hypertrophic cardiomyopathy news. 2 big RCTs, both published in New England, were presented at ESC. Both trials tested myosin inhibition, and the disparate results turned on the type of hypertrophic cardiomyopathy being tested, that is obstructive versus non-obstructive. The MAPLE HCM study studied the use of aficamten, next-in-class myosin inhibition that reduces myocardial hypercontractility by decreasing the number of active actin-myosin cross-bridges within the sarcomeres. Now, as background for MAPLE, in the Sequoia HCM trial published in 2024, aficamten outperformed placebo in patients with obstructive hypertrophic cardiomyopathy. It significantly improved the primary endpoint of peak oxygen uptake on a cardiopulmonary exercise test. It also decreased LV outflow tract gradient and improved quality of life, and this was a positive trial indeed. Now, MAPLE was an RCT comparing aficamten to metoprolol in 160 patients with obstructive HCM. It was a double dummy design, so patients could not tell their drug. The primary endpoint was also peak oxygen uptake, and it was assessed at 24 weeks. Aficamten beat metoprolol by quite a bit. Peak oxygen went up 1 milliliters per kilogram of body weight per minute in the aficamten group, and it went down by the same amount in the metoprolol arm, and that was highly significant, p-value at 0.001. Patients on aficamten also had larger improvements in New York Heart Association class, KCCQ, LV outflow tract, BNP, and left atrial volume index. And so there's no question this was a positive trial, and it challenges guidelines because right now, beta blockers are designated first line. But this first-line designation stems from almost no evidence, mostly just expert opinion and dogma, like we've done that. So again, I'm not a hypertrophic cardiomyopathy expert, so I can comment on the evidence part, but I would say that this is a good start in generating evidence. And it seems at 1.5 year, myosin inhibition looks favorable over beta blocker. But unlike beta blockers, which have been used for decades, we don't know the long-term effects of the negative onotropy of myosin inhibition, and I hope the FDA and doctors will require long-term data on this drug class. The average age of these patients in these trials was 59 years, so what are the effects at 2, 4, 5, 10 years of this drug? And of course, the other thing to consider in this situation is cost. These are expensive drugs. And again, we need to get some long-term data on them before breaking the bank. What if, for instance, they accelerate the decline of LVEF or increase the rate of malignant ventricular arrhythmias? I don't know that they will. I'm not saying they do, but surely 24-week data is insufficient. All right, the second trial was called the Odyssey HCM trial, and it had nearly 300 patients with non-obstructive HCM, and this was mavacamten compared to placebo, and at 2 primary endpoints changed from baseline to week 48, peak oxygen uptake and KCCQ. Sadly, myosin inhibition with mavacamten had no significant effect over placebo on either of these endpoints. Now, let me take a detour here for 1 second. The change in KCCQ from baseline in the mavacamten group was huge at 13 points. And you're like, whoa, that's a big increase, right? Well, it was 10.4 in the placebo arm. So the difference between placebo and drug was not significant. And this is exactly why the Triluminate trial is so problematic. Yes, the TriClip device improved KCCQ, but what would have been the improvement in KCCQ with the sham control, proper placebo? Would have Triluminate been exactly like the Odyssey HCM? Now, I'd say congratulations to the Odyssey investigators for having a proper placebo arm, but that would be unnecessary because all drug trialists know you need a proper placebo. Perhaps drug trialists could hold a seminar for trialists and devices and then teach them. Anyways, it looks like the presence of a significant obstruction selects for benefit of myosin inhibition in patients with hypertrophic cardiomyopathy, at least if we're looking at the relief of symptoms and short-term functional capacity. All right, next topic is on Vericiguat, and there were trials at ESC, and the title of the news article was, quote, "New data said to support Vericiguat as standard therapy for heart failure." Now, I'm going to disagree with that, and I'm going to try and explain it to you. As background, Vericiguat is a soluble guanylate cyclase stimulator, and it's already approved since 2021 for the treatment of patients with HFrEF. This was based on the Victoria trial, which found that Vericiguat reduced the combined endpoint of CV death and heart failure hospitalizations over 11 months by 35.5 versus 38.5%. This small difference represented a 10% relative risk reduction, which barely met statistical significance. Confidence intervals went from 0.81 to 1.00, and there were no significant differences in CV death. So this was a very small effect size and very much not statistically robust. Now, I have not seen this drug used once in my life, despite FDA approval. Maybe you've seen it used, but I haven't. Now, perhaps uptake of the drug has been weak because the effect size was neither clinically meaningful at 10% relative risk reduction, nor was it statistically robust, despite event rates more than 30%. Or perhaps it was because the trial was only 11 months. Well, at ESC, Vericiguat was going to try to make a comeback. We heard presentation of the Victor trial, also an RCT of Vericiguat versus placebo in patients with HFrEF. Now, these were ambulatory, less sick patients. Lancet published the Victor trial. 7,000 patients with HFrEF randomized. During a median follow-up of just 1.5 years, the primary endpoint of CV death or heart failure hospitalizations occurred in 18.0% of the Vericiguat group versus 19.1% in the placebo arm. That hazard ratio, 0.93. Confidence intervals go from 0.83 to 1.04. P-value not even close to threshold at 0.22. So for those counting, there were more than 1,100 primary outcome events, which is a lot. So a false negative seems incredibly unlikely. Victor is null, not significant, you could say negative. The authors write, quote, as pre-specified in the protocol, because the primary endpoint was not statistically significant, all analyses of secondary and exploratory endpoints are considered nominal. No matter, they went on to tell us and emphasize these things. CV death was 17% lower, confidence interval 0.71 to 0.97. However, heart failure hospitalizations, which was the other component of the primary endpoint, was only 5% lower, and the confidence intervals suggest it wasn't even close to statistical significance. The most common adverse event was symptomatic hypotension, which occurred 11.3 versus 9.2% in the active arm versus placebo. All-cause death was interesting, 12.3 versus 14.4, so that was reduced lower with Vericiguat. So the authors concluded, among patients with HFrEF and no recent worsening, Vericiguat did not reduce the risk of a composite endpoint of time to CV death or heart failure hospitalizations. Fewer cardiovascular deaths were observed in the Vericiguat group than in the placebo group, period. That's the conclusion. Then they add this down in the Lancet paper in those little boxes. It's the implication of all the available evidence. They write, quote, although Vericiguat did not reduce the composite primary of CV death and heart failure hospitalizations, the observed reduction in cardiovascular mortality suggests that Vericiguat might provide a mortality benefit in this population. Okay, so my comments. The authors try to explain how you can have a drug that reduces death or CV death, but not heart failure hospitalizations. And this is a hard one to explain. The explanation was that these ambulatory patients were on good medical therapy. I don't know about that. There were many more heart failure events than CV deaths in the trial, about 700 versus 400. So it's not like there were not enough events. I don't know about you, but A, this is a negative trial, and B, I'm trying to understand how a drug has no effect on clinical heart failure, such that patients are hospitalized to the same degree as placebo, but it magically reduces CV death. I think I would stick by the author's warning that since the primary endpoint was non-significant, all other comparisons are nominal. In my mind, Vericiguat as a therapeutic is dead. Well, no, actually, it's not dead. It's been resuscitated. How, you ask, has it been resuscitated? No, it's not with an impella, but a meta-analysis, of course. The meta-analysis can save the day. And for the win, this meta-analysis was pre-specified. So Lancet published the combination of the non-significant Victor and minimally significant Victoria trial. And this is the Vericiguat meta-analysis. Now we have 11,000 patients, 5,000 from one and 6,000 from the other. Now, we call that Victoria studied sicker HFrEF patients. The primary endpoint was the same, CV death and heart failure hospitalizations, and now it was 25.9 versus 27.9. So again, just a 2% absolute risk reduction, hazard ratio 0.91, confidence interval 0.85 to 0.98, p-value significant. And now there were similar reductions in the components, 11% for CV death and 9% for heart failure hospitalizations. And in this meta-analysis, the authors conclude that Vericiguat might be suitable as an additional treatment option for selected patients with HFrEF. And my comments, I'm not buying it. I don't believe these are clinically meaningful effect sizes. They are not statistically robust either. And meta-analyses are reasonable to increase power when individual trials are very similar and have low power. A good example is the post-MI beta blocker meta-analysis done for patients who have mildly reduced EF. In this case, individually, in each trial, the number of patients with reduced EF is not enough to make conclusions, but if you combine them, you get more power. But this is not the case with Vericiguat, right? Each of the trials, Victor and Victoria, had huge numbers of events, enough to sort signal from noise. And these trials enrolled different types of patients, and both showed individually very small, clinically insignificant effect sizes that either did not meet our threshold for significance or barely made it. So don't be fooled, friends. I don't see a role for Vericiguat over and above our 4 pillars of GDMT. All right, final topic today is a little bit more on Digoxin. The European Journal of Heart Failure published a small sub-study on September 2nd, and I don't think it was part of ESC, but it does deal with Digoxin, and so I wanted to mention it briefly. This was a post hoc analysis from the RATE-AF trial. RATE-AF, which was bisoprolol versus Digoxin in patients who had permanent AFib. JAMA published the head-to-head trial of the two drugs back in 2020. The primary endpoint of RATE-AF was quality of life measures. There were 17 secondary endpoints, and the main trial found that there was no difference in quality of life measures between the beta blocker and Dig arm, and at 12 months, 8 of the 20 secondary outcomes, were significantly different, all favoring Digoxin. The other 12 were no different. Digoxin resulted in better symptom control and lower BNP levels in the secondary endpoints. Surprisingly, adverse events were less common with Digoxin, 25% versus 54%. Now, the sub-study in the European Journal of Heart Failure, first author Carina Bunting, studied echocardiograms at baseline at 12 months, looking specifically at the change in systolic and diastolic function. Now, recall that these patients had permanent AFib about age 75, and there were 3 findings. First finding, in the 119 patients in the trial that had an EF above 50%, a significantly greater improvement in systolic function was noted in patients randomized to the low-dose Digoxin versus beta blocker. The adjusted mean difference for LVEF was small at 2.3%, but it was statistically significant. The second finding, for patients with LVEF 40 to 49, both Digoxin and bisoprolol induced increases in LVEF, and there were no significant between-group differences. And the third finding was that NT-proBNP was significantly reduced in the Dig group from baseline, but was increased in the beta blocker group. And so my brief comments, this paper was written before the DIGIT-HF trial came out at ESC. This sub-analysis is a provocative paper because I had always been under the impression that when patients with HFpEF and AFib, you're treating them and you need rate control, beta blockers would be best. But RATE-AF and this sub-analysis suggests that Digoxin is at least as good, perhaps better. The secondary endpoints, such as BNP, heart failure class, reduction of diuretics in RATE-AF, all favored Digoxin over bisoprolol. Adverse events, too, favored Digoxin. Now, RATE-AF is a different trial than DIGIT-HF. DIGIT-HF was done in patients with HFrEF. And recall, though, that 1/3 of patients had AFib in the DIGIT-HF trial. And there was no interaction of effect of Dig over placebo based on AFib or sinus rhythm in that subgroup analysis in DIGIT-HF. But it is very important to note that there is an AFib sinus rhythm interaction for beta blockers in patients who have HFrEF. I have mentioned this numerous times, but the Kotecha et al. Meta-analysis of heart failure trials, this is Lancet 2014. This is important. When they meta-analyzed all the heart failure trials, they found that the benefit of beta blockers is nearly all in the patients who have sinus rhythm. It turns out that 17% of patients in the heart failure trials had AFib, and beta blocker versus placebo, the Kaplan-Meier curves are superimposed. There was no benefit of beta blocker in the heart failure trials in patients who had atrial fibrillation. Therefore, when your HFpEF or HFrEF patient has AFib, digoxin seems like a highly reasonable drug. Please do take a look at that Kochecha et al. Lancet in 2014. Commit that to your brain or your smartphone. I think it's a really important study in heart failure therapeutics. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And if you like this podcast, please take the time to give us a rating, write us a review. These things help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.